All right, folks, you're behind the scenes with me and Secretary Shulkin. We're about to go live. Bear with us for about 10 seconds. We'll be going live. All right, everyone, greetings. Apologize for the slight delay. We'll try catching you up in the air. You have logged into Bright Spots in Healthcare. This is Eric Glazer. Welcome to our live recording. This show is produced by Shared Purpose Connect. We bring leaders together to not only inform our audience, but also unearth bright spots, successes at health systems, at health plans, and other healthcare related organizations around the country. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if the ideas shared on our show can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective strategy to improving healthcare in our lifetime. I encourage you to subscribe to Bright Spots in Healthcare, the podcast. If you have not already, you could find Bright Spots in Healthcare wherever you consume podcasts. You could get access to a library of incredible leaders from health plans, health providers around this country who are sharing their ideas and their successful tactics and strategies. Hopefully it inspires your thinking, maybe even promotes or inspires you to clone an idea and bring it to your organization. So please do that. And if you do enjoy the show, I ask you the favor of giving us 5 stars and maybe writing a comment or testimonial in whatever podcast app you use. All right, we can't do this show each week without the support of some of our commercial partners. Today's sponsor is Insignia Health. Thank you to the folks at Insignia. If you do not know about them, they develop tools and technologies that assess and support patient activation to improve patient care across the healthcare industry. Their foundational offering is the Patient Activation Measure. You know it as PAM. Their clients include not only private healthcare systems and health plans, but also the Centers for Medicare and Medicaid and NHS in England. Check them out at insigniahealth.com. I'll tell you a little bit more about them later on in the show. All right, today's episode, one that I've been looking forward to personally for a long time. We have with us Dr. David Shulkin, the former U.S. Secretary of Veterans Affairs. Secretary Shulkin is a national thought leader on veterans health, but also patient-centered care. He was appointed by President Donald Trump as the 9th U.S. Secretary of Veterans Affairs and served in the role from February 2017 until March 2018. He also served as the Undersecretary of Veterans Affairs for Health under President Barack Obama. The Department of VA, for those of you who are not intimately familiar with it, is actually the second largest federal government agency, and the Secretary oversees the National Cemetery Administration, the Veterans Benefits Administration, and the Veterans Health Administration. Under Secretary Shulkin's leadership, the department streamlined the appeals process for veterans seeking disability benefits, made wait times more transparent, and improved mental health services. If you are interested in learning more about some of the innovations being done at the VA and the immense challenges of running an agency of that size, I encourage you all to pick up the book, It Shouldn't Be This Hard to Serve Your Country. I'll repeat that title. It Shouldn't Be This Hard to Serve Your Country. It is written by our guest today, Secretary Shulkin. As someone who read the book, this is a fascinating firsthand perspective on both healthcare strategy and innovation, veterans health and benefits, and the politics of working in a prominent role within a government agency. Before Secretary Shulkin's time in government, he had a long career of healthcare leadership and management, including at the University of Pennsylvania Health System, now Penn Medicine, as well as Temple University Hospital, Beth Israel Medical Center, and the Morristown Medical Center. So super excited to have you here, Secretary Shulkin. Welcome to Bright Spots in Healthcare. Are you ready for this?
I am, Eric. Let's get going.
All right. Let's start. I'm going to do an icebreaker because you talked about it in your book, and I just love for you to set the stage and allow folks to get your, a little bit of sense of where your perspective is coming from. You got to work under 2 very different administrations in prominent roles. Could you talk a little bit about some of the advantages and disadvantages of working in both administrations that had very different cultures to them. So you could kind of transpose them, and then we could get into some of the questions about some of the cool things that you did at the VA during that time.
I'd be glad to do that, Eric. You probably couldn't even invent two very, very different styles of administration between the Obama administration and the Trump administration. They were at polar ends of the spectrum. And of course, now that seems like old news. At the time, I was learning about this in real time and just couldn't believe how different these organizations were. I entered government in the Obama administration at the end of the Obama administration with 18 months left to go. And I would say that was a fine oiled machine. They had been in leadership for 6.5 years. They knew what they were doing. They had a defined way of doing things. President Obama is very methodical and analytic. When you meet with the president, you present weeks ahead of time, detailed briefings, reports with data and analysis that his staff goes through. You respond to a series of questions. The president will have read the material before he meets with you, and he will have questions and have thought about the material, much like a college professor would, in terms of that type of detail and thought in terms of the subject. And so in the Obama administration, things were very methodical and sometimes slow and sometimes difficult to innovate in, because the issue was thought about from what the consequence of a decision would be, what the secondary consequences would be, and maybe what the third level consequences would be, to make sure that we weren't going to make mistakes. When you go to the Trump administration, it's exactly the opposite. When I would go to meet with President Trump, and the first time I brought in briefing materials, he said, "I don't want those." So I never brought them again. He did not want to have a lot of detail and analysis. And the access to the president was direct. So you didn't go through a lot of layers of staff that would ask you questions. That led to quicker decision making. That led to the ability to get things done on a much more rapid scale. But it also led to some decisions that, quite frankly, may not have been thought out quite as well and did have unintended consequences to them.
Probably a microcosm of different cultures at different organizations across this country, and maybe a microcosm of a lot of the hospitals you probably entered into as an executive. Oh, could we talk a little bit? By the way, folks, there's a Q&A module. Our regulars know this at the bottom of the Zoom interface. You could submit your questions there, and I'll try to integrate some questions. You could co-moderate with me to Secretary Shulkin as we flow through our conversation today. I would love to talk about, I think, as someone who has personally been in healthcare for a while, we don't necessarily think about the VA as a place to look for innovations or bright spots, as I call them. So I would love for you to talk to the leaders at health plans and providers in our audience today about why they should be looking to the VA to maybe discover some things that they could maybe apply at their organization, and how to innovate in healthcare, or at least benchmark off the VA to innovate in healthcare.
Well, first of all, I want to try to correct that impression. The VA is a place that has created much innovation. The very first liver transplant was done at the VA. The cardiac defibrillator, the radioimmunoassay, the first hemodialysis, the work that led towards the CAT scan, the fact that we know that aspirin prevents cardiac events, the first bar-coded wristband for medications invented by a VA nurse, the patient safety field led in large part by the VA, the willingness to acknowledge errors and to do team-based training, the first major electronic health record in the country led by the VA, the VISTA system, which was a homegrown system. So this is a system that is filled with innovation and filled with the ability to continue to innovate. When I got to the VA, one of the first things I did was I put on my white coat, my stethoscope, and I started to practice medicine. And I saw a very different way of being a doctor than I had in all the years that I had spent in the private sector being a doctor. So one of the things I did was I took 400 veterans who were paralyzed, had lost their limbs, their arms and their legs, to a mountain in Aspen, Colorado, and went skiing with them, and saw the impact of being able to take people and have them regain joy in their life and competition, and what that did to their well-being and their mental health. And so it really broadened my view of what healthcare means, the definition of health and wellness, and many, many innovations are happening in the VA as we speak.
Can you share some bright spots or examples that you may think are actually like the historical background is super inspiring, but what about some bright spots that you believe maybe are clonable today for the private sector? I know you mentioned some in the book, but maybe you could share one or two that you think, geez, if a lot of the industry did this as well as we did, we'd be all better off.
Well, I think there are two things that come to mind, and I could go on about it. In fact, let me just tell the listeners that when I came to the VA, I was, as you mentioned, I was running a private sector hospital in New Jersey and spent my career in the private sector. I thought, I'm going to go in and I'm going to show those guys how healthcare is run. I'm going to take these best practices from the private sector and I'm going to fix government. And in fact, it turned out to be exactly the opposite. I learned so much from the VA healthcare system that private sector CEOs should be doing. That what the VA does is a holistic approach towards healthcare, because remember, they don't have to worry about the third-party payers. They don't have to worry about whether they get paid for what they're doing. Every year I would go to Congress and I would say, I'm going to be taking care of 10 million American veterans. I need this amount of money, and Congress would give me that budget, and then I could spend that money really in the best way that would benefit veterans. And that allowed me to focus on many of the things that people today call social determinants. If veterans can't get to their appointments, we provide them transportation. If they are homeless, providing good health care to patients who don't have homes is a difficult thing. So we would find them homes, first temporary shelters and then permanent places to live. If people needed good food, we'd provide food security. If people needed their medications, we'd provide them their medications. And so this sort of social determinants approach towards healthcare, I think, is something that the private sector really can learn and benefit from. But of course, many people in the private sector are stuck in a reimbursement system that rewards under a traditional medical model. But I think one of the other bright spots that I'd like to mention is what the VA has really evolved from their team-based approach towards delivering healthcare. And, in the VA, healthcare is delivered around a primary care model where mental health is integrated into the primary care setting. So there's not this separation between behavioral healthcare and mental healthcare. It's done together. The newer version of that is called the whole health model. And this is a model that really, I think, holds significant promise. And it's the intersection between three ways of delivering care. The first is that the VA teaches self-care. It actually trains the patient how to be an advocate for their own health care. And sometimes that means helping them understand their condition, helping them understand the right questions, but it gives them tools such as mindfulness and Tai Chi and yoga and other tools for self-care. The second is it actually trains peer advocates to help people navigate the health system. And I think all of us know the system is so fragmented and complex. Having an advocate is really important. And that's particularly true for veterans. So training other veterans to help take a veteran through the healthcare experience and being a trained navigator is something that VA's created a job description for. And the third is training the team, the healthcare team, to work together as a team. So understanding that a pharmacist, a social worker, a psychologist, a dietitian, a specialist, and a psychiatrist are all part of the team that cares for veterans. When you intersect those, that's called the whole health model. And what we've seen now with 285,000 veterans who, with more than 2 years of data, who have been integrated into this whole health model, we've seen a 30% decrease in costs. We've seen a 300% decrease in opioid use. We've seen much greater engagement and decreased burnout among employees. We've seen a reduction in pharmacy costs from 15% to 4%. So these are big, big changes by changing the model of healthcare. And that's one of those bright spots I think that the private sector can learn from.
Love that. I'm gonna stick on the team approach. You mentioned pharmacy costs. One of the bright spots in your book that just sticks in my head that your answer just stoked a memory of is the Shark Tank program you put in place. I don't know if you put it in place, but was in place. And one of the things that came out of that Shark Tank process during your leadership was this pharmacy-led medication management program out of Wisconsin. Could you, just give the group a high level of what the Shark Tank program was like, and maybe they could implement it at their organization if they don't have a similar one already, and then what that pharmacy-led medication management program was or is?
Yeah, I did put the program in place. I can't take credit for the idea. I had two favorite TV shows at the time. This is before I got into Netflix binging. One was Shark Tank on ABC, because I'm a basic entrepreneur and I loved watching that happen. And the other is Designated Survivor, which ultimately I became the designated survivor. Yeah. So it shows that sometimes TV does come true. But when I got to the VA and I formed my priorities, one of the things I found was the culture of the VA was to be competitive with one medical center against another. In other words, VA had something called the star rating, and it was a star rating where it compared one VA medical center to another. And that led towards a competition where VAs didn't want to share their best practices with one another because they were competing against each other. And that made no sense to me, because what we were doing in the private sector was, as health systems were coming together, hospitals were consolidating, we were actually integrating best practices and standardizing care across the system. But the VA was very much, each VA stood on its own, and I wanted to change that. And the way I sought to change that was by doing Shark Tank. And I created Shark Tanks all over the country for VAs. And instead of having billionaires who served as sharks like ABC does, like Mark Cuban, my sharks were medical center directors, the people that ran our medical centers. And the way you would win Shark Tank is you would come and present an idea, and the most sharks, the most medical center directors that would vote to commit to taking your idea and implementing it across the system, that's how you would win Shark Tank. So it wasn't with money, it was by committing to implement these systems across the VA system. And one of those winners of Shark Tank was a young woman who had been a pharmacy intern in Madison, Wisconsin, Elena Sakel. And she came up with an idea that pharmacists could actually do a better job prescribing medications than doctors. And what was so interesting about this idea was that at the time, the VA had a severe shortage of primary care doctors. We were burning them out. We were trying to fix the wait time. We were putting more and more patient loads on them, and they were essentially resigning in large numbers. And so the Madison, Wisconsin VA had a 40% vacancy rate of primary care doctors, and it was going the wrong direction. And what Elena did was, by having pharmacists take on the prescribing responsibility for medications, she was able to remove a large part of that workload away from the primary care doctors. And so they created clinics of pharmacists that would do the medication management. And that began to let the doctors have more time. And pretty soon, they were able to fill those spots. and really improve the satisfaction of primary care. It also turned out that the pharmacists did a better job with medication management than the primary care doctors did. So we took that idea, which was proved out at the Madison, Wisconsin VA, and once it won Shark Tank, we began to spread that throughout the country. And of course, using federal supremacy law, I was able to allow pharmacists to practice at the highest level of their license and do this type of prescribing. And it's something that I think really has worked well and has created great satisfaction for the pharmacist. So instead of working behind the counter at CVS, just counting pills and putting them in bottles, pharmacists actually get to manage medications.
Love that. And were the medical directors who have to implement, they obviously have to use their own budget and reallocation of budget to implement. They're not getting any funding from the mothership.
No, and this was not a hard thing to do because budget, when you have a 40% vacancy rate of your doctors, is not the issue. It's finding people who are willing to come into the environment and feel it's a good place to work. And once the pharmacists started helping take some of that responsibility off of the primary care doctors, it became a better environment and they felt more supported.
And that leads to the clinical politics, not the politics of shifting a very traditional responsibility of an MD, of which you are, to someone that is not. Sometimes when those ideas come to fruition, they are immediately shot down, never get past sort of the water cooler. Was there any backlash around that, and how did you overcome it?
Interestingly, the single most controversial issue that I ended up taking on as undersecretary was the decision I needed to make whether I would give advanced practice nurses independent practice authority. That means whether I would allow nurses to be able to practice independently and see patients. And I got 400,000 letters, emails, and phone calls on this topic. Everybody seemed to have an opinion, split right down the middle, 50% for the idea, 50% against it. But I literally heard from every member of Congress who either said this is a terrible idea or this is a great idea. I don't know if people understand or realize this, but in Congress, there are actually nurses caucuses and doctors caucuses, and every professional group watched my decision because it could be precedent setting. In the end, I used the principle that unless you have access to healthcare, you can't have good quality care. And I ultimately decided to grant nurses full practice authority. That was a big factor in helping us solve our wait time crisis. It gave nurses the ability to practice in settings where, frankly, we didn't have any doctors, like in rural parts of the country. And I watched what happened with the quality of care, and I think that it actually helped improve quality of care. And as a primary care doctor myself, I've practiced with nurse practitioners, and frankly, I've practiced with nurse practitioners that I thought were better than I was as a primary care provider. So I had confidence that if you do the right job in credentialing and privileging, that letting nurses and pharmacists and other professionals practice at the top of their license where they're trained to do, that you can have good results.
Right. And you mentioned wait time. So I want to go there. And I also want to get into sort of go back to whole person approach and bring in the digital as a topic. Before I do that, I just want to give a little bit more run to our sponsor today. I want to thank Insignia Health. Those of you who join us late or are not familiar with that name, Insignia Health has they're embedded in patient activation research. They also develop platforms and have been consulting in this space for over 2 decades, providing leading solutions around patient activation assessment, as well as patient health coaching and engagement resources, and how these work across multiple verticals, including hospitals and health systems, health plans, carriers, other carriers, pharmaceutical companies, and the governments around the world. So they're really the expert around sort of consumer engagement, patient activation. They are the exclusive distributors of the patient activation measure, PAM. which, as many of you probably already know, is that 10 or 13 item survey that measures patients' current knowledge, skills, and confidence to manage their own health and healthcare. So I want you to learn, if you want to learn more about them, they're at insigniahealth.com. If you want to meet their CEO, just to pick their brain about some of the things you guys are doing around patient activation, I'm happy to make a personal introduction to Chris Delaney. He is their CEO and someone who I've begun to work closely with, and so much they collaborate on a lot of our programs. So if you want to meet Chris and get a one-on-one introduction to him by way of yours truly, I'll have Sherry, our producer, put up a quick little poll, and anyone that says yes, I'll just make a quick introduction. All right, David, let's get into the wait times, and then we'll circle back to digital, because you teed it up really nicely. So, and this is really my transition to strategy talk in general. You mentioned in your book, and you just alluded to it, that when you took over as undersecretary in 2016, one of the biggest publicly documented problems at the VA was waiting times to seek care. However, you went on to say that the key to solving that problem, and I know you mentioned the advanced providers, but one of the keys was to actually identify the true metric that had to move the needle, and the one that enabled you and your team to focus on the most effective solution, you said, was not how long were veterans waiting for care, but actually was the question, which veterans needed to be seen first. And so when I read that piece, it reminded me of another book called Moneyball. It's been mentioned on the show a couple of times. Those of you who are unfamiliar with that book, and it's also a movie, it's actually a baseball book, but it's actually got a lot of business implications. So if you're not a baseball fan, I would still recommend you reading it. It's about a general manager by the name of Billy Beane, who led the underfunded Oakland A's and allowed them to compete and defeat larger market, bigger payroll teams by finding value where other teams didn't see it. Basically taking the status quo statistics that led to more runs and victories and challenged those assumptions to find other statistics that actually were more predictive of scoring more runs and thus devalued and less expensive. So that's the stage I want to set for this question, because by identifying wait times, that wasn't the stat that had the most value for you, or at least it wasn't the one that enabled you to make those remarkable improvements in a short period of time. So I want to allow you to talk through how you came to reducing those wait times by taking that approach of choosing the less traditional, more generically accepted number, and what was your thought in doing that, and maybe just the overall mindset in healthcare of how we have to challenge ourselves to look at other metrics to make dramatic change.
Eric, whenever you take on a problem, and when I entered the VA in 2015, I clearly had a burning platform, and that was to solve the wait time crisis. It was a national scandal. It was on the top of minds of the president, of the Congress. The previous secretary resigned because of it. The previous undersecretary was let go because of it. Most of the senior management in the VA left the VA because of the failure of addressing this issue. So I came in, and this was clearly my burning platform. And whenever you take on a big issue, I think it's most important to get the problem that you're working on clear, to define it by asking the right questions. And so the metric that had been used by VA all along was that they wanted to get veterans appointments within 14 days. And so when I arrived at VA and I saw the data, they had 557,000 veterans waiting more than 30 days for care. And that was really thought to be a very, very large number. And I asked the question of the VA team as soon as I got to VA, well, is 550,000 veterans waiting more than 30 days for care, is that good or bad? And most people looked at me like, we must have found the stupidest undersecretary that we could ever find. I mean, what a dumb question. But I meant it genuinely. I've run a lot of large health systems, and if I looked into my computer scheduling systems over the course of the next couple months, I would see tens of thousands of patients scheduled for care. And as a CEO of a private hospital, I would look at that and I would say, that's good. That means that people want our services. That means that they've scheduled follow-up care. They're scheduled for preventative mammograms and colonoscopies. So simply having care scheduled out into the future is not a bad thing. And you certainly don't keep that as the right metric. What you really want to know if you're running a healthcare system is, are people getting the care when they need to get the care? Is the clinical need matched to the appointment time? And so I asked the question, I said, I don't care how many people are waiting more than 30 days for care. What I care about is how many people that need to be seen now who have an urgent medical problem are waiting for care. So they went back and they looked at the data, took in the VA system where the data is integrated, it didn't take very long. They came back and they said, okay, there are 57,000 patients, veterans, waiting for urgent care more than 30 days. I said, now that means something to me. That's not good, because the definition of urgent care as a clinician to me says that for a stat consult, you should be seen in 24 hours. And as a primary care doctor, if I had a patient who had an urgent need, I would often not let them leave my office till I knew they had an appointment with a specialist, or they went to the emergency room, or there was follow-up before they left my office. So now that I knew that we had 57,000 patients who had an urgent problem waiting more than 30 days, I said, now I understand the problem and we have an urgent situation. And I called for what is a national stand down. It had never been done in the VA. It's been done in the military. We've just seen it actually recently be done by the new Secretary of the Department of Defense, where he called a national stand down over racial issues. That means that every member of the military stops what they're doing and they enter a training session over the issues of race in the military. That's how urgent the secretary felt that was. So I called for a national stand down to see 57,000 patients urgently. And the very next weekend, we kept every VA medical center open across the country. I went to the Philadelphia VA. I sent my senior team to places around the country. And our goal was that weekend to see 57,000 patients who needed to be seen. And by Monday morning, we had less than 1,000 patients left who had not been seen. We couldn't contact them, or they had gone other places for care. And so once I knew that there were no longer veterans waiting for urgent care, I needed to put in place systems to make sure that that list wouldn't just build back up, because that's what happens when you focus on a problem too often. Once the problem's solved, your eye is taken off of that problem and it begins to rebuild. And a couple months later, you find you're back to where you started. So the only way that I knew how to fix this problem permanently was to go to same day appointments. That means that if you have an urgent problem, you should be seen that day. And if you do that, if that's your system in place, then you never rebuild, because everybody's seen on the day that they have that urgent problem. And by December of 2016, right before President Obama was preparing to leave office in January, I was able to tell President Obama that we put in place every VA medical center across the country had urgent medical problems with same day appointments across the country. And that gave both him and me the reassurance that we had really addressed the wait time issue. And just to be sure, because I see one of the questions that had popped up on the Q&A screen, so how is the VA in terms of wait times? When I left VA, I actually did a study that was published in JAMA, where we compared the wait times in the VA to the wait times in the private sector. And the wait times today in the VA are far better than the private sector, statistically better. And if you take a look at the period of time when I came to the VA, 2016 through 2018, the VA's wait times went down significantly where the private sector stayed flat, had not made improvements. So it just shows, again, as a bright spot, that when you as a leader focus on an issue and you make it a priority, you can make a difference. And that's what we did at the VA. And I feel very comfortable that the VA is still doing well. One of the final things that I did was I made sure that we published all of our wait times. We are the only healthcare system in the country that publishes publicly its wait times for appointments. So you can actually go on the website and you can see what the wait times are for VAs anywhere across the country. And that will assure the accountability to make sure that this problem does not recur.
I love that. I love it. I'm hesitating here because I really don't want to bring in politics into this conversation, but I also want to speak to leadership, benchmarking, and education, and the folks who are listening, who want to sort of become even better leaders than maybe they already are. And so, to that end, I'd love to ask you this. So, one is, so there's a question from an audience member right now that says sort of VA's worked really hard at being a quality organization, as well recognized for that, but is faulted for being unresponsive and unable to meet veterans' needs. Why this economy? So I'm not going to ask you that exact question, although you could address it. It's really about, so why when there's a bright spot as a leader of a government agency or a major hospital that gets a lot of press, how can leaders ensure that the bright spots get highlighted, especially to the consumers they serve, the constituencies they serve? In your case, it was veterans, or maybe it's like patients in the greater Philadelphia area, depending on what your role was. And then how do you look at the media? Because one of the things that your book enlightened me to, and it wasn't like I was totally naive to this, but is that the media is largely inconsistent or inaccurate in some, or at least biased in their rendition of a particular issue or topic. So as leaders who are listening, how do you manage highlighting the bright spots and not being overwhelmed or overreactive to how the media may cover your blemishes or your challenges?
Well, I'll touch on really three parts of that very briefly. The first is really the question that was asked by the listener. The VA is a very large system, the largest in the country, and it is under a public microscope. I would say that often things that happened in the private sector, when I ran hospitals for private hospitals, academic hospitals, bad things that happened in my hospital would often stay in the CEO's room. They would come and they would talk to me about it. I would be very concerned about it. We'd address it. Sometimes we do confidentiality agreements with the patients and their families to compensate them, but we would try to keep it relatively quiet. There is no such thing in the VA system. Everything that happens that is an adverse event is generally a public event. I will often, as secretary, get called before Congress on it. It would often be a front page story in the newspaper, so that the type of transparency and focus on VA's issues gets so much more attention than things that happen in the private sector. So it's not necessarily a level playing field. The VA in general has very high satisfaction scores, quality scores that generally are at or above where the private sector is. It doesn't mean it's not a system with problems. Every healthcare system has problems, but I would not say that it's a system that is unresponsive to veterans. There are situations where that occurs, but that's not generally the way I view it. Secondly, I think the issue about how you deal with with trying to get your story out there. I think that the job of leaders is to be good communicators and to be transparent. One of the first things that I did as secretary, against the advice of my entire media team, was I went to the White House, I went to the briefing room, and I addressed all of the national press corps, and I told them the 13 major problems that the VA had. And people said to me, that's about the dumbest thing you could do. You're letting the media know all your problems, and you're giving them the stories that they're going to cover during your entire term. And I just didn't know any way to address the problems if I don't talk about what the problems are. And if I don't let people know what I'm trying to work on and why I'm working on them. And it's the reason in Washington, I thought the VA continued to have the same problems decade after decade between Democrats and Republicans, because people weren't willing to come out and address those problems head on. And if you don't tell people what the problems are, you can't ask them for their help. How could I ask Congress or the White House to help me solve a problem if I wouldn't tell them that we had the problem in the first place? So I believe very much in talking about when you have problems, and also talking about when you solve the problems and the progress that you're making or the lack of progress that you're making. And I would regularly schedule press conferences to do exactly that. Now, the issue about the press, I too struggled with the press in Washington. Just like healthcare has changed dramatically, some people may say not for the better, where it's become much more economically oriented over the past couple decades. I think the press has changed as well. The fact that there are so many media outlets and people are racing to get to a story, to break the story, and the fact that the click by ad revenue drives the media right now means that reporters, unfortunately, are willing to skip what you would traditionally call the normal rules of journalism, where it used to be that a reporter would have to get at least 2 independent confirmations of a fact before they print a story, and they would have to disclose who those sources were. It now is, you can print a story by simply saying 2 anonymous sources told me that this was true. And therefore, it opened up the press to be essentially able to be manipulated by the political partisanship. When political opponents want to get somebody in Washington, they now have lots of people who are willing to print the scandal of the day, the rumor of the day. Sometimes they're true, but often they're essentially not true or exaggerated. And I think it's made being in public service a very difficult place in which to do your job right now. And it's a gotcha environment. And unfortunately, I think the press plays into that. And that's not to say that the press is our enemy and that the press doesn't have an extremely essential role in a democracy. I do believe that they do. But it has become a very challenging place for a public official to work in, given how quickly you will find outlets who are willing to publish almost any story.
Yeah. So I'm going to come off this just briefly because I know we're getting tight on time and I want to get into digital. And incidentally, folks, next week's episode, which is the April 15th, we're going to actually do the live recording at 2 p.m., so 11 a.m. on the West Coast, and we're going to cover the virtual front door in healthcare, and we're going to have a debate. So it's the first time I've done a debate, folks. So if you're not interested in the topic and just want to see me struggle with something, you definitely want to tune in. 2 o'clock, and it's on the West Coast, and it's going to be a debate between 2 CEOs, one at Giant Health and one at Decoded Health, and their different approaches to the virtual front door. And Sherry, why don't we put up a poll? If you guys want to attend that, we'll register you. So just click yes. We have your contact information already, and we'll just register you so you have that, and you could attend live next week. So Secretary Shulkin, I know that I'm a big believer that mental health and primary care are one of the same. I know you are as well. How is digital virtual care enabling providers to provide more effective team-based collaborative care between primary and mental health care providers? And I guess the follow-up to that would be, how should our audience think about bringing programs to their consumers in this vein?
I think that telehealth and virtual care, digital care is at the early stages of impacting our model of care. Right now, it's seen as primarily technology, and it really needs to transition into providing a value add for both patients and providers. So I've detailed what I call the 9 stages of telehealth. I think most of us think about telehealth at what I call stage 1, which is the asynchronous and synchronous use of telephone and video as a way of communicating. I think that's just the beginning of where we are headed. By definition, I'm saying there are 8 additional stages beyond that. And I do think that one of the important parts of that is that it can facilitate what you call this team-based approach to care. So at a VA medical center, a primary care doctor in their exam room has a digital tablet that if they want to bring in a mental health professional, they can simply hit the digital tablet and a mental health professional is available to join them in that examination, in that consultation with a veteran. And that can help bring in the type of expertise into a primary care setting that I think is something that we should be striving for. So technology is an enabler. Once the technology begins to allow the patient to participate more in their care, I think that's also a good additive step. It's part of this whole health model that I talked about, the self-care, allowing the healthcare providers to practice in team approaches to bring in specialty expertise as part of that, and then allowing peers or caregivers, particularly in chronic care settings, to participate through a digital or a telehealth experience is also something I think is so important. You know, so many of us have the experience of a family member who sees their doctor and you ask, well, what happened in the appointment? And they really don't remember, or they're not sure exactly what the doctor meant or how to interpret what the doctor said. I think allowing an advocate, a caregiver, a peer advocate to be part of the healthcare experience is an important way that we can use technology as well.
Is there a program or an approach at the VA that you believe was better than most, where maybe the private sector should be like looking into it to clone it, or at least look into it and on what they're doing as it relates to mental health and primary care?
Well, I think delivering mental health services in the primary care setting works very well. I think it's a challenge because of the reimbursement in the private sector. And that's something that we need to fix. When we allowed the insurance industry to separate physical medicine from behavioral healthcare in a separate capitation type system, that ultimately was a decision that impacted our clinical model of care in a negative way. We now need to begin to start integrating those together. And I think the research shows that when you deliver good mental health services, it actually helps reduce the cost and improves the quality on the physical side of the healthcare equation. So it just demonstrates these systems need to be integrated, not separated.
Okay. And by the way, folks, if you want to sort of connect and learn directly from Secretary Shulkin, he's got a blog, and I think the 9 steps that he just alluded to are in his blog. It's at shulkinblog.com. So that's one place you could kind of connect and see all the great ideas coming out of Secretary Shulkin's mind. And then you could also follow him on Twitter at David Shulkin. So 2 ways to stay following Secretary Shulkin following the show. 2 final questions, because I know we're tight on time. The first one, so Jack Welch used to always have his CEOs of his divisions come in and do these quarterly postmortems that if the department was shut down, what are a few things that, looking back, they needed to think or do or execute differently. I'm going to, after reading your book, it's clear that your tenure as secretary was not necessarily a walk in the park, to put it lightly. When you look back at that experience, if you had to go back in time and do it all over again, uh, far from saying no to the president and not taking the role, can't do that. What would be like one thing you would have done differently as secretary?
Well, I relive that story in my mind all the time because I have to say that this past year during the pandemic has been really hard for me sitting on the sidelines. That given my personality and given the strong commitment I have towards mission, I wanted to be in government during the pandemic more than anything, contributing. And frankly, again, not trying to be political, but trying to be objective. I thought that the administration, I'm talking about the Trump administration, fumbled the pandemic. I give them credit for Operation Warp Speed and bringing the vaccine so quickly to market with a private-public partnership. That's something that they should be proud of. But the way that we handled a public health emergency was horrific. And more than anything, I wish that I had been in the cabinet as an experienced healthcare professional and physician, because I know I would have tried and stepped up to try to help influence the process. So I rethink that question. Should I have done whatever it took to stay in the job so I could have been there longer? And ultimately, I made a decision, right or for wrong, that when I was asked to violate principles that I believed, I was not willing to do that. And you always have to make a decision. You saw this with a lot of cabinet officials. Are you better off compromising your principle to be there? Because if you're not there, you don't know whether the next person is going to be able to even deal with the issues and protect the country in the way that you know that you feel confident in your own abilities. And so, but there were many times during my time as secretary where the president or the administration did things that I felt I needed to speak out upon. And when you speak out against the president, there is potentially the interpretation that you're being disloyal, and you could get fired. And that's one of the consequences. I happen to believe when you speak out on behalf of a principal, you're not being disloyal. You're actually doing your responsibility, the oath that you took, because you're trying to make a better decision that will protect the American public. So it's a very tough question. I spoke out against the president's remarks at Charlottesville. I felt that was inappropriate. I felt I couldn't stay silent. I spoke out when I disagreed with the administration on the Agent Orange issue, where I felt that we had an obligation to honor our commitment to our veterans, and the administration didn't like that. And I spoke out against privatization. That ultimately led to a shortened tenure, and I was willing to accept those consequences.
I know we're coming up. Do you have time for one more question? I don't want to.
Sure.
Okay. Folks, by the way, you've already received in your inbox another email from me. I know, a lot of emails from me, asking for your feedback on topics we should cover throughout the rest of the year and how you enjoyed today's show and how we can make shows better. Those of you who are new to us know that I take those very seriously. I'll keep on emailing you requests to take that survey because we use that as our gospel in making sure we continue to make this show as valuable as we can and earn your hour each week. So just know that that's there. Last question for you, Secretary Shulkin. Thanks so much for all this time. This has been great. You mentioned in your book that your approach to strategy and leadership can be defined as set, do, and report. And I'd wonder, like as a closing kind of anecdote or answer, if we could provide us all with an example of when this approach worked in spades, and maybe how leaders listening can apply this approach at their organization.
Yeah, this is really this set, do, and report is really a simplistic way of saying a leader needs to set the vision and set the goal. Then the leader needs to make sure that then it's implemented, that the resources are provided to get that done. And then you have to be publicly accountable for the result. So I'll use a very quick example. I asked the question in the VA, how many veterans had hepatitis C? Because a new drug had come out with a 95% cure for hepatitis C, which I thought was remarkable. And it came back that there were 167,000 veterans in the VA system with active hepatitis C. So as a leader, I went to Congress and I said, I am going to cure hepatitis C among all veterans in the country. There should be no reason why veterans should have hepatitis C now that we have this drug with a 95% cure rate. And Congress said, that's great. And I said to them, all I need now is $1.5 billion to get this done. And they gave it to me. And once I had the resources, I went to the VA and I said, now we're going to contact every one of those 167,000 veterans, and we're going to call them into the VA, and we're going to tell them that we can cure their hepatitis C, and we're going to do proactive outreach by doing that. Today, there will be less than 10,000 veterans in this country with hepatitis C. And those people have decided for a number of reasons, mental health issues, other reasons, not to decide to get the cure. But that's essentially a functional zero, or we've eliminated hepatitis C. Now we need to report that out, and we need to monitor it to make sure that that doesn't climb back up, and consistently make sure that no veteran who wants to be treated for hepatitis C goes untreated. And so that would be an example of the set, do, and report.
Great. Love it. Thank you so much for the time and the privilege to get to meet you and to be on the show. I really appreciate it. Folks, next week, April 15th, we'll do that debate, 2 p.m. East Coast time. Thanks to our friends at Insignia Health. Secretary Shulkin, I'm going to ask you to hang out for 1 minute. I'm going to just dismiss everyone. Thank you. This marks the end of the show. We will see you next week. Thanks again.